Welcome to Her Body and Mind podcast. My name is Dr. Ciara Fox.
My name is Amanda Sarich, clinical counselor.
And today we're going to be talking about PCOS, so Polycystic Ovarian Syndrome, which I know Amanda's a little bit familiar with. Yeah, a little bit. But obviously don't understand a lot of nuances. Now, this particular topic kind of loops in slightly to our last podcast episode, which was talking about Ozempic and drugs like semaglutide and tirzepatide, because PCOS is definitely rooted heavily in a blood sugar insulin resistance picture. And those drugs do help with blood sugar insulin resistant pictures. So yeah, there's a lot of crossover, but this particular episode is important for a lot of reasons. One, because of how common PCOS is, but a lot of women don't realize or recognize that it's that common and therefore kind of count themselves out of possibly having it. And there's a lot of reasons why a lot of women aren't diagnosed. It's a very underdiagnosed condition, I would say, and yet probably in the top 3 conditions that I treat in my practice.
Okay.
So I would say like perimenopause, menopause is huge. PCOS is huge. Thyroid conditions are huge. And then other like period related stuff like heavy periods. But PCOS definitely in the top 3. And my daughter personally, she actually has PCOS. And so, yeah, there's a lot to this subject for me. I'm very passionate about it and I'm excited to share.
And so knowledgeable. Like everything I know is from you.
Yeah. So as far as like PCOS goes, like what is it? So a lot of confusion as far as like stereotypical presentation. So PCOS, the name, Polycystic Ovarian Syndrome, it's not even like a very accurate title. And I think they're currently working on renaming it because not everybody with this syndrome has ovaries that are polycystic. So meaning that have more than 10 cysts. So premature follicles that have kind of developed but arrested. So on ultrasound, you can actually see these kind of string of pearls, they call it, where there's more than 10 kind of follicles that are underdeveloped but there. So you can actually see it in ultrasound. But a lot of women who have PCOS, actually, you don't get that on ultrasound. So women will get an ultrasound done. They're like, nope, you don't have it. But that's not actually true.
Okay.
So from a diagnostic criteria perspective, there's a few different camps, which it's like this in a lot of like, whether it's, Canada, the US to Europe, everyone's kind of got their own criteria they use to diagnose things, which makes research and stats very difficult because when you're not using the same parameters to determine if someone has a condition, there's a lot of variance in like prevalence and does it exist? Doesn't it exist? So it's odd. But what we classically use is something called the Rotterdam criteria.
Okay.
So if you come into my office, that's what I'm using as my tool to determine if there's this syndrome, which a syndrome, to be clear, is a diagnosis, but it's more so a collection of symptoms that kind of add up to a particular picture, kind of like IBS, irritable bowel syndrome. It's like a syndrome, but usually there's a reason for that syndrome, if that makes sense. So Rotterdam criteria, there's 3 things and you only need to meet 2 of 3 criteria.
Okay.
So one would be to have irregular periods, which I'll define after. And I actually just got kind of the most recent definition of how we defined irregular period off of an article that was written just last year. So irregular periods is one. Second would be either having physical signs of high androgen/testosterone. So physical signs being cystic acne that happens in the jawline, chest, back, or even facial hair growth. So thick, coarse hair growth, jawline. So not just like little peach fuzz, but it's like the coarse hairs where you like feel like you want to laser or pluck because you don't like them.
I have lots of those now. But I think it's from
different reasons.
Perimenopause.
Yeah, different, which that can happen too. Yeah. Or in that second criteria, or on lab and diagnostics, we can see that testosterone is actually high.
Okay.
So one in that second category, you can have either physical signs or you could have no physical signs, but then see the androgens on labs. So a little nuance there. And then the last would be actually seeing the polycystic ovaries on ultrasound. So you can see why you you can't meet, or you shouldn't have to meet all three, because as I noted that sometimes people don't have the positive ultrasound, or some people have no acne, like no physical signs, but then you will see that on labs. Some women have totally regular periods, but they might have acne. You know what I mean? So there's, as far as like PCOS and what we classically perceive or see spoken about as what that might physically present with, or even metabolically present with, it's a huge spectrum.
Okay.
Just like any disorder that has like a spectrum of presentations. But that's why a lot of women get missed, because as soon as a doctor finds out that A, that you have regular periods, B, let's say that you're in your late 20s, early 30s, and you've had babies and there's no fertility issues, they also will be like, there's no way that you could have this, but you're gaining weight like crazy and you have facial hair growth, but you have a regular period, so it doesn't matter. So they'll never do the deeper dive to actually see. So there's so many barriers or reasons why women get missed for this. Yeah.
Huh. Okay. Just another thing women are having to fight for.
Yeah, totally. Now let's talk a little bit about irregular periods. And this, I'm going to read it because there's, again, a lot of nuances with irregular periods. The age in which you have irregular periods, because that matters too. Because obviously, you know, a girl might get their period at age 12 or age 15. And then, you know, how much time do we give them before we consider it irregular? Because this starts at a very young age. I mean, in utero, or even while you're being developed, like this is heavily rooted in genetics as far as why someone develops PCOS. But as far as when we start to see the presentation, isn't until we reach menarche, and then we start to be able to sometimes track our cycles and see the change there. But there's, as you know, other pieces. So,
well, this is probably a total sidebar that we might not talk about, but because I specialize in trauma,
yep,
there's a lot of people on my caseload with PCOS.
Yes.
And there's some documented connection between early childhood trauma and a later development of PCOS, correct?
I actually, as far as like that goes, I'm not aware of that like stat, and whether or not, I mean, that's an association, and what that means for, I don't know.
Maybe not causation,
but yeah, that's an interesting one that I would like to look up. But definitely stress and trauma can cause more inflammation in the body, which then would for sure fuel whether it's a stronger presentation, because this is something that a condition that if, and not everybody with PCOS, but some people can more easily manage it through diet and lifestyle, where you never actually manifest it fully, if that makes sense. So if there's trauma and stress and cortisol and cortisol dysregulation, therefore inflammation and eating disorders because of that, and you know, not moving because of that, and then that's going to fuel the condition. It will make the condition worse. So I would say that that's true. I can make that make sense, but was that the cause, or is that contributing factor to the severity? I don't know. Yeah.
Chicken egg.
Yeah, totally. Now let's talk about irregular cycles, because this is confusing for a lot of people. So I'll just kind of read this out. So 1 year post menarche in the puberty transition. So let's say your daughter gets a period for the first time. That first year is kind of like we take that with a grain of salt. It really doesn't mean anything. Like you really, like at minimum, need to give the body at least the year, but sometimes longer than the year before we start to be like, oh, like is something awry? And then within the first 3 years of, you know, from first period to then 3 years after that, what we're looking at is having cycles that are longer than 21 days and shorter than 45 days. So within that 3 years, we want the period to be at least 21 days. So it has to lie basically within 21 to 45 days. So a normal classical cycle, for reference, is 28 days, including your bleed. Okay. So the days that you bleed plus the days between, it's usually 28. So what we're looking for in the first 3 years is between 21 to 45 days is what you want to see as far as like a pattern.
Big variance.
Yep, it is. But that's still considered regular in the first 3 years when you get your period. And then after that, so from year, like it's been 3 years and then on to perimenopause. That's the next like hormonal shift where we actually start to see things changing again, is what you want to see is your periods being within 21 to 35 days. Okay. So anything outside of that would then also be considered irregular. And then another thing is if you don't get your period by age 15, and actually when I first started my practice, it used to be age 16. So now if you don't get your period by age 15 or within 3 years of seeing like breast bud development, that is also considered irregular.
Okay.
And warrants investigation. And that could be PCOS, but that could be other things too, to be fair. All of this could be a few other things, but this is just defining irregular periods regardless of cause.
Yeah, because Dr. Fox is not diagnosing anything. We're just looking at like broad symptoms that can be under this umbrella.
So this is just defining irregular periods. And like I said, above and beyond PCOS, lots of other things to consider. But this, when we're defining it and using irregular periods, that's what we're kind of using.
Okay.
So we talked about that. Now, prevalence, I mentioned it. If we're using the Rotterdam criteria, between 8 to 13% of women would be diagnosed. Or that not be diagnosed, but meet criteria for Rotterdam, versus the National Institute of Health. If you're using their parameters, only 4 to 8% would meet criteria, so less.
Okay.
And then if you look at like all the research done across all the lands in the world, it's between 5 and 26% of women being diagnosed. This is like using, like looking at all the research, the highest prevalence and the lowest. So 5 to 26% of women, if we're considering all the different types of criterias and diagnostic things. So you can see there's a lot of variance, but at least 10% confidently, I can say, of women have polycystic ovarian syndrome.
Which is a massive number.
It's a huge number. Think of 10 women that you know. Like really though, 1 in 10.
Yeah.
That's a huge number of people. And yet there's not enough research. Doctors don't diagnose this or even consider it as a factor in a lot of different cases. And therefore, and when we talked about GLP-1s, GIP-1s, semaglutide, Ozempic, all that, the big thing there is like, you know, what is the risk of having a particular condition if undiagnosed or just not treated? Yeah. And in this case, because it really impacts your metabolic function and your risk of diabetes, cardiovascular disease, all that, there's huge risks and consequences with it not being diagnosed or it not being managed properly. And so that's why this is extremely important above and beyond just, you know, the other pieces, which is, you know, if your periods are irregular, it can make fertility a little bit more challenging depending. And so there's a lot of things that we can do to support this population, but it's really first like having the tools to assess and understand that it's a spectrum and that everyone presents differently. And my daughter I'll use as an example, because I think with most people when they see things on social media, if they look up PCOS on the internet, there's these pictures. There's pictures of women with PCOS, cartoons, whatever. And it's classically, you know, a woman who might be losing her hair because of high testosterone. That's what can happen. Who has the acne, you know, there's like the facial hair growth and more visceral body fat. So a lot of fat stores abdominally, versus my daughter is, you know, tall. She's 5'7", 5'8", quite slim, athletic looking, you know, and so if she was walking into a regular GP's office, just based sheerly off physical appearance, without any other information, this would never be a consideration for her. Yeah. And she's only just now 18 and has high testosterone, high DHEA, irregular periods, you know, all these things, which sometimes you can have PCOS, but those symptoms won't turn up until your late 20s or 30s, which is also confusing. Yeah. Like, gosh, you don't have symptoms until you do. And that also makes it confusing, because why didn't you have symptoms when you're younger? Why are you suddenly gaining weight in your 30s and you can't control it? There's reasons. And I catch it all the time. 35-year-old woman coming to my office, gaining weight, had babies, has regular periods. Why?
Yeah. What's the why? What's the root?
Possibly PCOS. Very possibly.
Sounds like there's like big risk factors for not getting diagnosed. Like if that's going to increase your risk of, you know, death, probably good to consider it at least if you have some of those symptoms.
100%. And then going to family history, and we talked about genetics with relationship to insulin resistance and, you know, how we respond to foods, or even like hunger and cravings, all that. We talked about that in our last episode. We're talking about Ozempic and PCOS. I mean, we're still learning so much because there's still not enough research on this, but there's so many different genes now that we actually know are tied to this as far as like the cause. And depending on which ones you have or how many, you know, that can also dictate the severity and how you present and how it's managed. and so there's a lot of pieces there, but what we do know for sure is genetics is for sure like a big driver in this. And then there's other things that, we talk about our environment and endocrine disruptors and things that can impact our hormones in a negative way just from, chemical exposures, etc. The big ones, we talk about household items and cosmetics and things like that. They can contribute but genes, like genetics is the huge piece here. And then that goes back to then understanding that you don't get to choose this. And I think that once people learn this, because they're like, PCOS, are like, no, that can't be me. I don't want to be someone with PCOS. They're like, no, I don't. Let's just pretend. It's like not like something that people want to have tied to them.
Well, it sounds like because of the negative stereotype types, the cartoon drawings on the internet.
You got it. That's what it is. And just like, I can't, they're like, I don't want to identify. I can't really, no, that's not. And I'm like, well, even if it is like this, it's good to understand that like you didn't do this to yourself. Because when we talk about type 2 diabetes, again, people think like, like I'm so bad and I did this to myself and I ate those chips and I didn't work out for a month.
That's right.
That happens. Everyone goes through that. And some people stuck in those phases for longer, but like the reality is that you don't choose this. This is there. And it's just knowing that about yourself and knowing the pieces and of PCOS that are impacting you and then learning the proper management strategies, because it's something that can be managed and quote unquote reversed in some cases, but really the bigger piece is making sure that we don't develop things like endometrial cancer or diabetes or cardiovascular disease because it's not managed properly.
Well, that's where this idea like knowledge is power. Again, shame. We talked about it with the Ozempic episode, last episode. This idea that you did something wrong, that you caused this, that you used too many chemicals or ate too many chips, that you created this is probably not helpful.
No, it's definitely not good. Okay. So that's like, assessment, how do we look at it? How does the world view it? Prevalence. We kind of talked about a lot of the symptoms. So we're talking about irregular periods, high androgen symptoms, which is hair loss, facial hair growth, cystic acne. And again, going back to my daughter, she never had jawline acne. She had temporal. Yeah. Temporal, which is again unique. She did have some chest back stuff, but it's like never there. So again,
lots different. Of variation in presenting symptoms.
Lots of variation. Some women can have really light periods. Some women can have really heavy periods. I think that from anxiety, depression perspective, these are huge in this population, comorbidities as a result of A, the hormonal imbalance, and then B, the distress that metabolic dysfunction actually causes in the body. Because it's a stressor, like truly. So those are big pieces. Worsening of ADHD if it's already there, for sure. So there's a lot of things. And then fertility, I think I want to really clear this up. A lot of people, the reason why they're like, no way, no, PCOS is not for me, because if it's a younger female, the first thing you hear about is like, well, you can't get pregnant.
Right.
People say that, and that's not true either. It could be the farthest from the truth. Like women every day get pregnant with PCOS. There's ways to regulate it so that your periods are more regular, so you ovulate consistently, so that you can have the babies. You know what I mean? So that's another thing that I think is out there as far as like people thinking it's fact when it's the farthest thing from the truth.
Which again, I mean, I don't have a lot to offer to this, but I think that's the same thing I just keep saying is like knowledge is power. Knowing what you're experiencing, getting diagnosed properly, then allows you to have a totally different experience with any type of symptom, right?
Yeah, totally.
What about treatment? So how does that work? So I'm a female, say I don't think I have PCOS, but say I did.
Yeah.
What would you do to help me?
Yeah. So as again, like the research article, the meta-analysis that I was reading as far as like the new definition of irregular periods, and that I was just looking at classically, what is suggested for management strategy pending like what particular piece of the syndrome you're tackling, because different pieces like irregular cycle versus facial hair growth versus fertility. These are all addressed sometimes in a different way, but classically, if you were to go into your GP's office for the irregular cycles and even for more the androgenic symptoms, they would suggest an oral contraceptive, so the pill.
Okay.
And often what happens is that you're actually never diagnosed with PCOS. You just say you have irregular periods. Like, let's say you're 18 years old. You're like, I think I should have a regular period. I don't. So you see a medical doctor and they're like, well, let me regulate that for you. I'll just put you on the pill. And then you go on your way and you're on your pill and now you have regular periods. But you don't. So the pill doesn't actually regulate your natural rhythms. What it does is it gives you a small amount of hormones within like the active pills in the kit.
Okay.
And then it gives you, generally, depending on which one you're using, 7 days off. So you get a withdrawal bleed. So it's not your hormones causing that withdrawal bleed. It's the hormones in the pill. Right. So then you perceive yourself to have regular periods, but you don't. And in this population where this has or is happening to, what happens is then maybe by age 25, 30, they're like, I want to have a baby, so I'm coming off the pill now. But they get off the pill and then they have no period because they had no idea they had PCOS 10 years ago. And now the condition has progressed because they didn't even know there was a condition to manage, and then they don't have a period. So that's something that happens very often. So not that the pill is bad, but it masks, and before going on it, we need to understand what the reason was. And then you can use it as a tool because we don't want women with PCOS to not have a period because that sets you up to have increased risk of endometrial cancer. But we also want to understand what the cause is before then using it maybe temporarily to help with, your androgenic symptoms or to help with your bleed so you can bleed consistently. So it's an option, though it's not the only way to manage those symptoms that I'm referring to, but this is what a GP would offer. So that's there. I don't use oral contraceptives for that reason, though it's a great way to prevent pregnancy. Super good. But if you don't need the pill for that, then there are other ways to go about regulating, which is working on the insulin. Sometimes there's an adrenal aspect to this. So working on cortisol and the adrenal gland so you're not overproducing DHEA, working on the inflammation coming from the liver, working on the blood sugar, which there's a ton of tools for, which is diet, lifestyle, gut health. And then there's supplements like berberine and NAC and inositol and chromium, lovely things that can help also co-manage to help kind of bring things. But everyone's an individual, so not everyone has all the pieces. Right. So not all the tools are going to work in the same way. You really have to look at the person and look at also PCOS that maybe also has Hashimoto's because they're very related. Like as far as comorbid conditions that happen at the same time, there's a lot of other conditions that are linked that I always screen for because they often happen together, and hypothyroid being the biggest one probably.
Okay. So AKA work with someone who knows this in this way to kind of be able to understand it. Yeah. Because it sounds quite complex.
It is. And then going back to like other things, so fertility, regulating cycles, because there's ways to regulate the cycles if we can kind of bring the hormones back, which we can. But there's also pharmaceuticals that can help with fertility to kind of help bring things in a more regular way, which is things like letrozole is used all the time pharmaceutically to help with regulating ovulation or making ovulation stronger. So those are kind of like the bigger things as far as treatment goes. And then going back to our last episode on GLP-1s, GIP-1s, semaglutide, tirzepatide, using these injectables for management. Now here's the interesting part. And I did some research on like the history of research in relation to these drugs and PCOS particularly. Okay. And it's only been since 2020 where there started to be small studies done on PCOS with semaglutide. So that's the GLP-1s. And just in the last year or two for tirzepatide, but there's nothing actually, they say right now for tirzepatide, that is proven yet. Though, okay, so you have someone who has insulin resistance, metabolic dysfunction. We already have all the research and all the land on these drugs in, being obese, having, visceral fat, type 2 diabetes. We know how they work. We know that people with PCOS have all those issues. And yet we can't say like, this is how research works. Unless there's a study to prove it, you can't actually say that it works. Right. And that's the new, like me being a naturopathic doctor, it's like, we've been using things for hundreds of years that work, but it wasn't until research caught up that we could actually say that it worked. Right. We know what works. So these drugs work in PCOS, but there's still like, even with the semaglutides, there's still like a kind of like, well, maybe it looks like a pretty good idea, but like there's still like so much hesitation to be like, use this in PCOS. But I use it in PCOS and it's great. They're great.
You heard it here first, people.
They do. And we've done a lot of other things. And some people, they respond so nicely to like these very conservative methods with diet and lifestyle and, you know, supplements. And it's amazing. And I get great results and it's beautiful. And then sometimes there's like stubborn cases where you're like, what is like, it just won't, the body is just in a particular state genetically, whether their iron's also low and their thyroid's up. There's so many different things that we can't test for, that we can't see or know. But then we use them. We're like, oh, great. Okay, now your periods are regular. Oh, okay. Now you got pregnant now. Like, that's great. So anyways, there's a lot of different avenues, but these drugs can be one of them. But the research isn't caught up yet to what we actually, if we're just talking about physiology and how your body works and how these work, how it's a really good combination. Sometimes. But I think what I hear is like there's a lot of treatment options. So Tons.
Although maybe some of the like, I don't know, outside world of PCOS makes it look bad, it sounds like there's some really good ways to navigate it and manage it, which is good. There's
so much. And I just think, just knowing that you have it and then not shaming yourself and just going for it and getting support and
no shame,
but it's just everyone's an individual. And especially in this, everyone's an individual. There's no cookie cutter treatment protocol for this. So if anyone tells you there is, you need to take a step back and be like, I need a second opinion, because that's a thing.
Yeah. Okay.
Yeah. I think that's it. Like, it's a good overview of it, and the things that we can kind of do.
Yeah, it's what it is, how to assess it. Lots of different treatment options. Work with someone who knows the things. Don't shame yourself.
Yep. Big one.
And Dr. Fox is real smart. I think that's what we're learning today.
Thank you.
You're welcome. So if you have any questions or comments for Dr. Fox about this, drop them below. She will answer them. If you have any questions or like ideas of things you want us to talk about, comment about that as well. Like, share, follow. Thank you so much for being here. I'm learning a lot. Hopefully you're learning a lot. We're learning a lot.
Yeah. Okay. We'll see you next time.
Bye. Please contact your own healthcare providers before you make any changes to your health and wellness protocols related to your body and mind.